A to Z of radiotherapy in ophthalmology. An ocular oncologist has to be a pantomath in terms of all the treatment modalities he or she has to offer. In cases where tumor is surgically inapproachable or as a part of neoadjuvant or adjuvant treatment, chemotherapy and radiotherapy play a vital role. Radiotherapy specifically has revolutionized over the past few years with improved outcomes and better safety profiles. In this video, we will be covering A to Z of radiotherapy in field of ocular oncology, including basics of radiotherapy, various modalities of delivery, techniques of delivery, surgical procedure, indications, and related complications. Basics of radiotherapy. Radiotherapy is a therapeutic strategy that impacts the DNA and interferes with the replicability of cancer cells by use of radiation in form of high-energy particles or waves. Electromagnetic radiation can be in form of X-rays or gamma rays. X-rays are generated by accelerated electrons, whereas gamma rays are emitted by radioactive isotopes. Particulate radiation includes electrons, protons, neutrons, alpha particles, negative pi mesons, heavy charged ions, and beta rays emitted by radioactive isotopes. Delivery modalities and techniques of delivery. Radiation can be delivered to the target tissue in two forms: teletherapy, when it is delivered from far, and brachytherapy, when delivered from a close contact with the target tissue. Teletherapy. External beam radiotherapy has evolved significantly over the period of time, starting from 2D EBRT, 3D conformal EBRT, IMRT, that is intensity modulated radiotherapy, where each field is subdivided into numerous beamlets whose intensities are individually modulated to achieve a non-uniform dose contribution from each field. In rapid arc modification of IMRT, with opening and closing of multi-leaf collimators, dose painting is achieved. Tomotherapy works on a principle of IMRT and delivers radiation by rotating around the body, aiming targeted beams at tumors from many angles. IGRT, that is image-guided radiotherapy, the workflow for which includes preparing a face mask. This is to manifest the superpower of our patients. Positioning with mask and infrared positioning, verification with X-ray, CT scan or MRI for anatomical matching of tumor, correction with 6 degrees robotic couch, snap verification at every couch angle, and finally the treatment delivery. Indications of EBRT includes lymphoma. In select cases of lymphoma, ultra-low dose boom-boom radiotherapy has been used effectively. Adenoid cystic carcinoma of lacrimal gland, orbital retinoblastoma, orbital rhabdomyosarcoma, fibromyxoid sarcoma, solitary fibrous tumor, primitive neuroectodermal tumor of orbit, or Ewing's sarcoma family of tumors. Proton beam therapy is a newer advance which delivers higher lethal dose to the tumor with minimal damage to the surrounding healthy tissue. Stereotactic radiosurgery works on a principle of stereotactically guided conformal irradiation of a target in a single session using X-knife, cyberknife, gamma knife, or tomoknife for ultra-precision. Indications of stereotactic radiation includes surgically inaccessible tumors such as cavernous hemangioma located at or near orbital apex, optic nerve glioma, orbital apex meningioma, orbital apex schwannoma, choroidal metastasis. Brachytherapy. With brachytherapy, biggest advantage is that the required dose is directly prescribed to the apex of the tumor, minimizing the damage to the surrounding healthy tissue. There are basically two types: plaque brachytherapy, which has surface application, and interstitial brachytherapy. Indications of plaque brachytherapy include uveal melanoma, retinoblastoma, choroidal hemangioma, choroidal metastasis, ocular surface tumors with scleral involvement, like ocular surface squamous cell neoplasia, lymphoma, or melanoma. Sources for plaque brachytherapy includes iodine, ruthenium, cesium, iridium, and palladium. Iodine and ruthenium plaques have key differences when it comes to their half-life, manufacturing, and the requirements for protection and maintenance. Plaques can be of different shapes. Notch plaque is used for the tumors near optic nerve, and round plaque is used for surface tumors. Surgical procedure for plaque brachytherapy. As per quadrant and size of the tumor, the plaque position is decided. For posterior placement of plaque, conjunctival peritomy is performed. Recti muscles are hooked and tagged for the appropriate traction. The quadrant of plaque placement is exposed and scleral markings are done from the limbus, where ethibond suture with a spatulated needle is passed through partial thickness of sclera, avoiding any sort of scleral perforation. Suture is now passed through plaque islets and tied. Position of the plaque is confirmed and conjunctival sutures are taken. Plaque removal is done as per pre-decided dosimetry timings by the radiation oncologist. Interstitial brachytherapy surgery. In this procedure, after debulking or excising the tumor, hollow needles or tubes are inserted in a particular pattern and distance from each other into the residual tumor bed. Closure will be done with the tubes in situ. As per the radiation planning, at the time of delivery of radiation, radioactive source will travel through the hollow tube and deliver radiation to the tumor tissue. Radiation is delivered in multiple fractions, with each fraction at least 6 hours apart. The interstitial implant is removed after delivery of all fractions of radiation. Indications for interstitial brachytherapy includes residual and recurrent orbital tumors such as adenoid cystic carcinoma of lacrimal gland and rhabdomyosarcoma. Complications of radiotherapy and its management: loss of eyelashes, thinning of eyelids, periocular pigmentation which is reversible, dry eyes, the incidence of which can be reduced by reducing dose of radiation to lacrimal gland by IMRT technique, keratitis which is seen when higher dose of more than 50 to 60 gray is used and can be prevented by keeping cornea out of clinical target volume, cataract, radiation retinopathy, or rarely central retinal artery occlusion. A superlative evolution in the field of radiotherapy has enabled ocular oncologists to plan an implicit management protocol in a more structured manner, ultimately benefiting the patient in terms of improved rates of life salvage, eye salvage, and vision salvage.